at least most of you, because pediatrics is not something that is relevant to most general physicians or sort of a general medicine people. So maybe something that is important, maybe as a parent, maybe as a primary physician, primary care physician, a very common problem that you encounter, and probably which you might not know how best to manage problems related to growth. So thank you again for the Clinical Society, Colombo Clinical Society, for organizing this and inviting. Growth problems are extremely common, extremely common. They are quite probably one of the most frequent questions the parents will ask whenever they come to take medicine for maybe some unrelated thing. If you are a pediatrician, just whenever they measure the weight, they want to know whether the weight is good. If you measure the weight, or if you sort of measure the weight in your general practice, yes, they will definitely ask, Doctor, Babage Bara Hondada, right? That's a very common question. Even if you don't measure the weight, they will show you the book with the CHDR and ask what's your opinion, whether this is good or bad. So it's a very common question that we all will encounter. It's again an indicator of serious illness. But I must emphasize that it's very rare, not very common, right? So most growth problems are simple things if you know the basics that can be managed very easily. However, it can be an indicator of a serious illness. But most importantly, the growth is very frequently mismanaged, especially by the field staff. We have lot of respect to the work that has been done, but when it comes to growth interpretation, the field staff are probably most of the time, rather than giving accurate information, they tend to provide inaccurate information. The common pitfalls that we see in relation to growth are, firstly, I think we tend not to measure growth parameters most often. As doctors, we are probably the worst lot. Whenever mother wants the weight to be checked, we tend not to sort of ignore, or we tend not to do that because it's time consuming and the proper equipment is not available. I don't know how many scales are available in the OPD, but if you run a general practice, you need to have an accurate growth monitoring equipment, which will be suitable for both babies as well as adults, unless you are not doing it properly. So measuring weight is an important thing which we don't do. Secondly, the weight that is being measured. So we know midwives will need sort of want you to bring your son or daughter to the clinic very regularly, but the way that's being measured may not be accurate. No point measuring monthly or every 2 weeks with improperly calibrated or improper equipment. That is commonly happening in the field. Nowadays, they are using the proper equipment, but still, most weighing posts will have, if you look at the growth chart, the growth is everywhere because it's being measured by using proper equipment as well as improper equipment. Thirdly, wrong interpretations and wrong management. So in the next few minutes, what I am going to talk to you is regarding how best to interpret and how best we can manage these problems, the common problems in an outpatient setup in a general practice. I'll be talking to you about two growth parameters, the two most important growth parameters, weight and height. In both, I'll be telling you the normal changes that happens during childhood. So you will have a rough idea and how exactly to measure it and what equipment should be used. And present some clinical scenarios which are very commonly seen in general practice. What you need to know is you don't need any sophisticated graphs to interpret growth parameters in children. The CHDR which parents carry will have all necessary charts. Everything is available in the CHDR itself. So, what I'm going to show you today are all pictures from a CHDR where that can be interpreted and managed very easily with in the general practice without any other sophisticated charts or anything. So, firstly, the weight. Before going into abnormal weight, we need to know what's normally happening to a weight of a child. The normal birth weight in Sri Lanka, average birth weight is 2.8 kilograms and the range is 2.5 to 4 kilograms. Less than 2.5 kilograms is known as low birth weight. More than 4, large for gestational age or large. So, low birth weight can be due to two main reasons. Firstly, it can be due to small for gestational age. In term babies can be less than 2.5 due to because they are small, which is also known as IUGR, but the terminology has now changed. Now we label it as small for gestational age. Or it can be due to prematurity. Premature babies anyway can have low birth weight, which may be appropriate for their gestational age. After birth, the weight will drop slightly during the first 5 to 7 days. So weight loss is universally seen and in every baby that will happen. The maximum allowable weight drop loss maybe because we are recording it, it doesn't allow me to go back. But let's see. There are several factors that will affect the weight and growth. The birth weight is primarily determined by the maternal factors. Maternal size, maternal nutrition, maternal illnesses, and birth order will determine the birth weight. So genetics will have a very limited impact for the babies on the birth weight. However, when it comes to postnatal growth, weight and height after birth is determined by two main factors. One is nutrition, number two is endocrine factors. During infancy, the growth is predominantly determined by nutrition. So the main factor that will cause growth problems during infancy is poor nutrition. However, during childhood, the impact of nutrition becomes less and the impact of hormones, especially the growth hormone and thyroxine, will be more. Linear growth specifically. During adolescence, sex hormones will play a role. So the infancy, the growth is determined by nutrition. After childhood, especially the linear growth is determined by growth hormone and thyroxine. And during adolescence by sex hormone. But for the weight, nutrition also plays a major role. Weight measurements are recommended monthly in children within the first 2 years. So wherever it's measured, that's not a problem. Every baby should be measured monthly during first 2 years and 3 monthly thereafter. You need to have proper equipment and weight should be measured with minimal or light clothing. In infants, weight should be recorded to the nearest 10 grams, that is 0.0 whatever the kilograms, and in children to the nearest 100 grams. There are 3 types of scales available. This probably is the best. Electronic digital scales, but properly calibrated in So with a good brand would be the best to measure weight. If it is an infant, you need this cradle type of scale. Older child, standing balance. So electronic digital scales are the best, provided they are properly calibrated and have a good brand. This is also recommended and this is also acceptable and probably almost equal to a properly calibrated electronic scale. These are known as beam balancers. So you keep the baby and you balance with your weights. Can be standing or can be cradle type. However, what we often see is that the weight is measured by one of these. If you take the field weaning force, these spring balance are used with a cradle. If you go to a general practice or even a hospital OPD, you see this type of spring bathroom scales which are not recommended to measure. So I think it's best not to measure weight using this. If you don't have a proper equipment, then probably don't measure. Otherwise, you will interpret it wrong and plot it wrong. So the beam balancers and electronic scales are recommended, but not the spring balancer. Right. So those are the basics about weight and weight measurement. And there we are going to move to few case scenarios, which we will see very commonly in general practice. Number one, small baby, a 21-day-old baby, a neonate, has had a birth weight of 3 kilograms and now the weight is 2.7 kilograms. So you don't even have to plot this in the growth chart. This is CHDR for those who don't know or those who are not very used to the CHDR. It's very important that all of us get used to the CHDR because so many information is available in the CHDR. But for this case scenario, you might not need the CHDR. A 21-day-old neonate, birth weight 3 kilograms, and comes to you at 3 weeks with a birth weight of 2.7. The normal, abnormal, if you plot, it will be something like this. If you plot, you obviously see that it's probably not normal. Why I am saying that? There's a 10% weight loss, but by 3 weeks, you would expect the child to have regained the birth weight and then be growing at a rate of 30 grams per day. Here, that's not happening. So there's some problem. What can be the cause? There are two main reasons. The most important thing is inadequate calorie intake or delayed or improper establishment of breastfeeding or lactation failure. However, this can be an indicator of organic causes. So how are we going to approach this? So this is a very common problem. I think about 10% of babies discharged from this hospital will come back with a weight loss of more than 10% or persistent weight loss, which we see. In the general practice, if you see this in the OPD, I think this baby probably needs admission because it's a neonate and have a problem which you may not be able to deal during or in an outpatient setup. First thing is to assess the breastfeeding. If there is a problem in breastfeeding, if there is a lactation failure, I don't think you need to go in detail into look for organic causes. Weight is the most important thing to assess the adequacy of breastfeeding. Adequately breastfed babies will have a normal weight gain. But here, it's not there. So the next important indicator of adequacy of breastfeeding is urine output. In any neonate, after 2 to 3 days, they will be passing urine, light color urine, at least 6 times a day. If the urine output is not adequate, that indicates there is a problem with feeding. The other indicators of inadequate breastfeeding are slept after a feed. Any newborn neonate after a proper feed will sleep for about 2 hours. So if that's not happening, there's a problem. The feeding, any normal newborn neonate will feed roughly 20 to 30 minutes. But if the feeds are not adequate, they will go on feeding for hours, which is again an indicator of improper breastfeeding. Letdown reflex is the dripping of milk from the other breast. when the baby is breastfeeding. It indicates adequate breast milk breast supply. And other thing you need to do, you need to examine whether the positioning and attachment of breastfeeding is correct. So the breastfeeding itself is a different topic, so I'm not going to go into detail, but first thing in that sort of a baby is to see whether the breastfeeding is adequate. Go for urine, look for urine output, and ask from the mother whether the child sleeps more than roughly about 1.5 to 2 hours after a feed and the duration of feed, and see, examine whether the positioning and attachment of breastfeeding is accurate. If there is a problem, you need to correct that. If the breastfeeding seems to be adequate, then you need to look for organic causes, any pathology that leads to poor weight gain, which are quite rare. Anyway, a normal examination, neonatal examination will exclude most of those things. But in a baby, there can be certain conditions that might not show anything, any physical signs. So even with a normal neonatal examination and correction of breastfeeding, if the weight gain is not adequate, then I would recommend doing certain investigations like full blood count, CRP, to look for any occult infections, UFR, urine culture, to exclude a urinary tract infection, and to do other basic investigation, provided that the breastfeeding is adequate and the neonatal examination is normal. Creatinine, electrolyte, random blood sugar, because certain conditions like renal tubular acidosis or chronic renal problems in neonates can give rise to poor weight gain, which are very rare. And AST, and a venous blood gas, because certain metabolic abnormalities might present with failure to thrive. So the take-home message is a neonate who's having failure to thrive, two reasons, lactation failure or organic causes, rarely. The most important thing is to assess and optimize breastfeeding. So, if the cause is lactation failure or delayed establishment of breastfeeding, both terms are used. Optimize breastfeeding, positioning and attachment. We sometimes use, although there is no proper evidence, some lactobose, domperidone or metoclopramide can be used if the milk production is inadequate. Expression of breast milk, expressed breast milk can be given as cups, and as a last resort, probably a decision from a consultant pediatrician, maybe you might consider supplementation with artificial formula milk. But that's the last resort, and probably it will be decided by a consultant. I think that is number one. Case number 2, we move on to a 6-week-old baby who had a birth weight of 4.7 kilograms and coming with this growth chart. Has gone to the field clinic, midwife is furious, the weight is crossing centiles, and as usual, has told the mother that the weight gain is not adequate and there's a huge problem. What do you think? Yes? So we obviously see there's crossing of centile lines, which we think may be alarming, right? But if you look at the birth weight of the child, it is 4.7. It seems to be maybe the problem itself. Maybe the problem is not the current weight, but the birth weight. So most likely this baby was a large 4 days baby, maybe due to maternal gestational diabetes mellitus or some other problem. Baby is gaining weight but crossing centile lines. The best would be not to intervene at that stage, but to follow this baby up. This is known as catch-down growth. Babies who are large for gestational age will generally come down to their growth potential by crossing centile lines, which is normal. We know there is something known as catch-up growth in small for gestational age babies. If the baby was born at a birth weight of 2 kilograms due to small for gestational age or placental insufficiency, they will show a rapid weight gain during first few months, which is known as catch-up growth. When it comes to large gestational babies, inverse will happen and there will be a catch down growth, and after when they reach the potential weight centile, they will grow along the centile. So no investigations are required, just reassure us, but remember to follow them up. So that maybe if you see the during follow-up, if you see this, that is obviously it is catch down. Right. Third case, another common clinical presentation. So the baby has born with a birth weight of 2.5, right, marginal, and is having this growth chart. What do you think? Again, every time the weight is measured in the field clinic, every time the midwife is not happy, weight is not adequate, and ask the mother to, there's no solution, but always claims that baramadi, baramadi, baramadi. So mother is refusing to go to the field very often. What do you think? So if you look at the growth chart, there is a weight gain. There's no crossing of centile, but the weight is less than the third centile, or minus 2 standard deviation. You do a full physical examination, and the physical examination is normal. So the baby is perfectly normal, except for this growth chart. The growth chart is also perfectly normal, right? You have to do a physical examination to make sure that there's nothing abnormal or any other features of chronic disease. Provided the physical examination is normal, this growth chart is normal. We know by statistics, plus or minus 2 standard deviations is only 95%. So 2.5% of babies can have a growth which is below the 2 minus 2 standard deviations or 30 percentile. So they may be growing along the centile line, provided that they grow along the centile line of their own, and this is perfectly normal. So no investigations are required. So just that baby should be let alone, right? So the no growth is normal. We can say for sure the growth is normal. Number four, another common clinical presentation. So the baby had the normal birth weight, growing along the centile line for 2 months, and then there is some sort of growth faltering during 3 to 4 months. Now the weight is 5.8. What do you think? Is this normal? It doesn't look normal, right? It doesn't look normal. There's some problem, right? Because the child has been growing along the centile line, but from 2, 3, 3rd month onwards, there is a problem. So again, two important problems are as similar to, because this baby is exclusively breastfed. So it can be due to problems with the calorie intake due to inadequacy in breastfeeding, which can occur after some time, around 3 to 4 months, or maybe due to organic causes. You do a full physical examination to exclude organic causes from the history and examination. You can do that. You don't have to investigate, right? So if that is the case, most likely that the calorie content of the breast milk of this mother is not adequate for the growth. The recommendation in Sri Lanka, or the WHO recommendation, is exclusive breastfeeding for 6 months. But for babies which shows this sort of a growth chart, it is always important that we start weaning early. Early weaning means you start weaning at 4 months. You can start weaning anytime after 4 months. So this baby needs to have calorie-dense food, solids, and the recommendation for that baby would be to start early weaning at 4 months. Breastfeeding should be continued and followed up whether the child is gaining the growth potential or coming back to the normal center. Formula feeding is not necessary, not recommended. What they need is energy dense solid, that is weak, right? So because now we have reached 4. Right. Number 5. Now we have passed the infancy, second year of life. 15-month-old baby has this growth chart, and the current weight is 8 kilograms. The growth starts flattening, maybe growth faltering and then probably flattening from 8 months onward. Is this normal? Obviously not. It is not normal. There's some problem. We need to evaluate. So we have this baby at 15 weeks, 15 months. But the problem probably started somewhere here. And to evaluate, we need to know the height of the baby, right? And these charts are all available in the CHDR. You plot the height. And if you look at this, this is the weight for length chart, which is again available in the CHDR. The most important thing in a child who has a baby who has a low weight for the age is to plot here. This gives you standard deviations, -2, -1, and the median, and -3 standard deviation. Any baby lying below the -3 standard deviation, the definition is severe acute malnutrition. Between -2 to -3 standard deviation is known as moderate acute malnutrition. So this baby has acute malnutrition, maybe on top of chronic malnutrition, but the weight length for age was normal. So there is no chronic malnutrition. So there is severe acute malnutrition. You do a full physical examination to exclude organic causes, and these babies may be best managed in the outpatient setting. Does not need admission. Unless they have severe infection, dehydration or electrolyte abnormalities, or loss of appetite or edema suggestive of any. All uncomplicated severe acute malnutrition children can be managed or best managed in the outpatient setup. The important thing is to address the root cause. If you remember the growth chart, you see that's been started growth faltering around 4 to 5 months, right? So that's the age. Around after 6 months, they start weaning, maybe some problem with the weaning. The most likely explanation is inadequate for the poor quality of weaning food that needs to be addressed. At 15 months, even if the weight is still not gaining, they may still be giving improper liquid weaning food, or the baby mother is breastfeeding excessively. So those root causes should be addressed. This needs treatment. The treatment is by ready-to-use therapeutic food, which are available in the government hospital from the nutrition clinic, which is known as BP100, and that 1 bar of BP100 contains 300 kilocalories, and BP100 should be given to all babies with severe acute malnutrition. Similarly, balanced diet should be recommended and vitamin supplementation, but most important, follow-up. So any baby with weight for length or weight for height less than -3 standard deviation has severe acute malnutrition. You need to exclude organic causes, address the non-organic root cause, maybe continuation of breastfeeding, excessive breastfeeding, poor quality of weaning food, but at the same time, these babies needs to be treated with ready-to-use therapeutic food. This BP100. And vitamin supplementation and follow-up are also indicated. Right. So from undernutrition or undergrowth, we are moving it towards overgrowth or overnutrition. So 5-month-old baby exclusively breastfed baby. And again the midwife is worried, because now it's moving from the green zone to purple zone. Normal, abnormal. Normal, abnormal. Yes. You again do a full physical examination, right, as a medical officer. If the physical examination is normal. This is a very well known phenomenon in breastfed babies. All babies will not follow the same growth pattern, same growth chart. Your growth charts are only references. So babies may behave in different ways. And it's very well known for breastfed babies, certain breastfed babies, to show a rapid weight gain during first few months. If the baby is otherwise normal, you are not worried about this growth chart. This is perfectly normal. You are not going to restrict breastfeeding at any cost, right? Restriction of breastfeeding is not recommended. You just let the baby breastfeed on demand, which is the recommendation, and start weaning appropriately at 6 months. When the baby starts roll and walk, this growth curve will flatten and the baby will come to the normal growth potential. So this is very well explained in breastfed babies. Nothing should be done provided the baby's physical examination is normal. Even if they are in the purple zone, even if they are in the dark purple zone, nothing should be done. You should not restrict breastfeeding. Right. Case number 7, a 10-year-old boy comes to you with abdominal pain and he seems to be obese. Now we are moving to overnutrition, right? So looks obese, weight is 45 kilograms. Is this baby obese or not? So it looks obese. Right? But you need to prove that scientifically, whether this baby is obese or not. How can we do that? You need 2 parameters. You need to check the height. And then, as in any adult, anyone above 2 years, the BMI is the important indicator of obesity. You can't diagnose obesity without any other indicator. Any child above 2 years, you need to calculate the BMI to diagnose obesity. After calculating BMI, this BMI should be plotted in the growth chart, which is available in the CHDR. So you don't need any other charts. You don't need to be in the pediatric ward. You just ask the mother the CHDR, and the CHDR will have in the current CHDR, page number 22. Any child after 5 years, you can plot it here. BMI above the +2 standard deviation for the age and sex is obesity in children. Between +1 to +2 standard deviation is overweight in children. So when you plot it, we know that this child is obviously obese. So this child is obese, so this child needs some management. You need to find out the cause for obesity. 2 main reasons. One is known as simple or nutritional obesity. That is, you are obese because you are eat lots. Or there can be pathological causes of obesity in children. Those pathological causes can be endocrine causes like growth hormone deficiency, Cushing syndrome or hypothyroidism. Can be certain syndromes like Prader-Willi syndrome, Down syndrome, Bardet-Biedl syndrome, or can be due to genetic mutations of the leptin gene, which regulates your energy balance, or there can be causes in the hypothalamus which are very rare. So it's important in any obese child to differentiate whether this child has simple, that is nutritional obesity, or pathological obesity. 3 features will help you to differentiate. 3 features in the history and examination will help you to differentiate. You definitely have to measure you have to measure the height. If the child is short and obese, that is an indicator of pathological obesity. Usually, simple obesity or nutritional obesity will cause tallness and obesity. So they will be tall and obese. Any dysmorphic features in the child will point toward a syndrome, again a pathological cause. Any developmental delay, hypothyroidism, Prader-Willi syndrome, these pathological causes are generally associated with developmental delay. So if the child has short stature, developmental delay, or dysmorphic features that points towards pathological causes of obesity, then needs to be referred to a pediatrician. If the child is tall, no dysmorphic features, normal development, it's most likely due to simple or nutrition or obesity, you might consider managing them in the dental practice. You don't always have to refer these children to pediatrician. However, if the child is in the category of obesity, the baby, those children needs to be screened for comorbidities, hypertension, hyperlipidemia, insulin resistance, and non-alcoholic steatohepatitis. So we routinely do blood pressure measurements, fasting blood sugar, and oral glucose tolerance test. Some would recommend HbA1c, lipid profile, ALT, and ultrasound abdomen in all children who are in the category of obesity, plus my 2 standard deviations. These are not required for big children who are overweight. These plus 1 to plus 2 standard deviations, these investigations are not indicated, only in obesity. The management is, as you always know, is quite tricky, right? Obesity management most of the time does not work very well. However, in children, you advocacy is what you need to tell is to maintain the same weight. We don't recommend weight loss. We don't recommend losing weight. But if you maintain the same weight for maybe 1 to 2 years, you will anyway grow in height, so the BMI will come down. So in children, you have to set a target to maintain the same weight approximately for 2 years. Recommendation for exercise is not 30 minutes for children, it is 1 hour per day, most of the days, if not all. Right? 1 hour aerobic exercises, but it doesn't have to be formal jogging or nothing. It can be just playing with friends or walking from school to home or whatever, but roughly recommendation is 1 hour per day. Dietary modifications as similar to others, maybe you would say refined sugar should be avoided, and then but again you need to give these advice thinking that this is a child, right? They will not be it has to be child friendly. Drugs are not recommended in children. Drugs to bring down drugs to counteract obesity are not recommended. So management of simple obesity in children is to screen for comorbidities, target setting to maintain the same weight, exercise 1 hour per day, and dietary modifications as you would know. Right. So we have another 5 to 10 minutes, I guess. Yes. And we'll be briefly discussing the next growth parameter, which is very important, is length and height. Normal birth length is 50 centimeters in babies. During the first year, they will grow about 25 centimeters. Second year 10, third year 8, and fourth year 7. Is a rough guide. So at the end of fourth year, they will be 1 meter tall. They will be 1 meter tall. Thereafter, they will grow at a rate of 5 to 6 centimeters a year until puberty. And at the puberty, there will be another peak of about 8 to 12 centimeters a year. So that's a rough growth in length or height in baby children. Again, the body proportions are also different in children. Normal adults will have a upper segment to lower segment ratio of 1 to 1. Lower segment is the distance from upper border of the pubic symphysis to the floor. Upper border of the pubic symphysis to the floor. From that to the head is upper segment. Normal adults will have an upper segment to lower segment ratio of 1, but if you take a newborn, the upper segment is much longer than the lower segment. The ratio is 1.7 to 1. Normal upper to lower segment ratio will achieve only at the age of 7 years. Length should be measured using proper equipment, which is known as an infantometer. Height should be measured using a stadiometer. The recommended frequency is 6 monthly in children. The few more important steps in the height measurement is to remove footwear, like clothes anyway, and your occiput, shoulders, buttocks and heels should touch the measuring board. May or may not be calf. Occiput, shoulder, buttocks and heels should touch the vertical surface. And the face should be kept in what is known as Frankfurt plane. Frankfurt plane is that your lower border of the orbital ridge. When you draw a line along the lower border of the orbital ridge, it should cross the upper margin of the external auditory meatus. So the head should be kept in that position when you check the height. Lower segment is measured from the pubic symphysis to the floor. The upper segment is height minus lower segment. What you need to know is that the upper segment does not mean the sitting height, right? Or the lower segment is sort of upper segment does not equal to sitting height. Nowadays, sitting height is no longer used. What we measure is upper segment and lower segment. This is important to see whether we are having proportionate stature, right? Proportionate stature. Last case, maybe I'll take 5 minutes of your time. A 7-year-old girl and the mother complains that she's the shortest of the class. And you measure the height, which is 100 centimeters, which you obviously know is not adequate because 1 meter height is achieved at 4 years, right? Anyway, you need to plot in the growth chart, again available in the CHDR, right? You don't need any other charts. All these charts are available in the CHDR and it's grossly inadequate. In any baby, any child with short stature, you need to do 2 basic things. That is to differentiate the causes of short stature. So these are the common causes of short stature. Familial short stature, because of the genetics you are short. Constitutional delay in growth and puberty. You will be short during childhood and adolescence, but you will regain a normal final height. Endocrine causes which require treatment. Hypothyroidism, growth hormone deficiency, and the important thing is to pick these because they require treatment. Chronic malnutrition, chronic illnesses, skeletal dysplasias like achondroplasia, and certain syndromes like Turner syndrome. So those are the common causes of short stature in children. With very few basic steps in examination and one investigation, we should be able to narrow down the differential diagnosis for short stature. First thing is to look for upper segment to lower segment ratio. In most causes of short stature, the upper segment to lower segment ratio will be normal for that age. But in skeletal dysplasias like achondroplasias, you will have longer upper segment compared to a lower segment. The next important thing is to look for the identify or calculate the mid-parental height to see whether the growth potential of this child is to the genetic potential. The way to calculate mid-parental height, I'm sure you all know, at mother's height and father's height. If it is a girl, to subtract 12.5 or 13. Some books will say 13, some books will say 12.5. If it is a boy, you need to add 12.5 to the mother and father's height and you divide by 2. Mother's height plus father's height. If it is a girl, minus 13 or 12.5. If it is a boy, plus 12.5 or 13. You divide it by 2, you get the mid-parental height. If you take a scenario, mother's height is 150, father 164.5, and that's a girl, the same girl that we discussed. So you subtract 12.5 from this, so it becomes 152. So the mid-parental height is 151. Again, you need to plot it in the proper place. But here you plot it is at 18 or 19 years. So this is the mid-parental height. So that shows if this depending on the child's genetic potential, this is where you want the child to be. But there will be a range plus or minus 8 centimeters. But you need to roughly assess is whether this child's current centile is lying within the mid-parental height centile. So obviously it doesn't seem to be. If it corresponds to the mid-parental height, it's most likely it's familial short stature. In these children, you need to take a history to exclude chronic illnesses or chronic malnutrition. Do a full physical examination that helps you to identify syndromes like Turner syndrome. The only investigation you will require at the initial stage is the bone age by doing an X-ray of the left wrist and hand. In familial short stature and disproportionate short stature like achondroplasia, the bone age will be normal. In most endocrine processes like growth hormone deficiency and hypothyroidism, the bone age will be markedly delayed compared to the chronological age. The cutoff is more than 2 years. So any child has a delayed bone age needs to be seen by a pediatrician. But if you are very confident that this child has familial short stature, that means the height corresponds to the mid-parental height centile and the bone age is normal, I think these children can be reassured even at the general practice setting. So that is the basic evaluation of a child with short stature. I think we have come to the end of the session, and in summary, the few take-home messages. In general practice, in our wards, in our clinics, we need to have proper equipment to measure the height and weight. It's very simple. You need to buy a normal, standard, calibrated electronic scale. Correct equipment should be assured, and you don't need any sophisticated charts. Everything is available in the CHDR, and mother will anyway bring that. So you just want to have to plot it, and most can be managed as outpatient. Right. I'm happy to take any questions if there are, and if time permits. Otherwise, thank you very much for listening.